So I would like to invite Dr. Ananda Basu, who is Harrison Professor of Medicine, Division of Endocrinology, Center for Diabetes Technology, University of Virginia. He's here to give a case-based discussion, automated insulin delivery. Dr. Ananda Basu, please. Yeah.
Thank you. Good afternoon, chairpersons, and thank you to the organizers of the International Diabetes Symposium. This is our fourth year, and Pune is almost our second home here in the US. So today I'm going to discuss about some of the future, the current as well as the future management of type 1 diabetes primarily, and eventually also type 2 diabetes with the so-called automated insulin delivery systems, or the so-called artificial pancreas. So I don't have any relevant disclosures. So the outline of this brief presentation is to give a quick review of current continuous glucose monitoring systems use, because CGM is part of the artificial pancreas. We'll talk briefly about the artificial pancreas systems currently in the US, including the largest multi-center clinical trial of its kind in patients with type 1 diabetes that was published in New England Journal from my university in October of last year, and end by a few case studies of the artificial pancreas in people with type 1 diabetes. So there has been data from the type 1 diabetes exchange that use of CGM has increased in the United States in type 1 diabetes, but the majority of people still don't use CGM in type 1 diabetes, at least till the year 2018. So as you can see, compared to the previous experience in yellow before 2012 to the current experience until 2018 in blue, there has been an increase, but more than 2/3 of patients with type 1 diabetes in the US do not use CGM. We are trying to increase that because obviously CGM use has been shown to be beneficial in patients with diabetes. In my clinic that I started in Virginia, the type 1 diabetes technology clinic, our current use of CGM is close to 90% in people with type 1 diabetes. This is also data from the type 1 diabetes exchange, which shows that doesn't matter what therapy you are using in patients with type 1 diabetes, whether it's insulin pump or MDI, adding a CGM improves glucose control throughout the age, in the pediatric age group, in the adolescent age group, and also in the adult age group. So just adding a CGM in patients with type 1 diabetes improves glucose control. So these are the current standalone CGMs available and used routinely in the US. The Dexcom G5 and G6. I currently use the Dexcom G6 in all of our patients. It's a real-time CGM that does not require any calibration. We have the Medtronic Guardian Connect, the Abbott Freestyle Libre, which is very common here, and of course the implanted Sensiomic CGM. I have not used it, but it is gradually getting more and more into clinical practice. So again, I won't go through the entire slide in the interest of time, but I will release these slides for Dr. Unnikrishnan to circulate. These are the various consensus statements from the ADA, et cetera, and the Endocrine Society on the use of CGM, especially in patients with type 1 diabetes. There are two different types of CGM. As we know, the CGM that is used most commonly in this country is the intermittently scanned CGM, or the Abbott Libre, where you have to take the reader close to the sensor for it to capture the glucose values, while we use most commonly the real-time CGM, which gives you real-time data, which is primarily Dexcom. Again, there are standards of care for use of CGM in type 1 diabetes, which the ADA endorses. Again, in the interest of time, I won't go through the most of the didactic sessions. And these are some of the indications for use of CGM in patients who are taking insulin, both type 1 and also type 2 diabetes. So this is the representation of a normal CGM. So as you can see, this is a healthy subject, and look at the tight glucose control in a healthy non-diabetic person. So really, if the human body spends so much energy to maintain the blood glucose levels within such a narrow range, it is because doing otherwise would be deleterious. And we all know about diabetic complications related to hyper and hypoglycemia. But I want to show this picture because this is a normal glucose profile in non-diabetic people in the audience. And to try and reproduce it or replicate it in a patient with diabetes is a distinct challenge. I don't think we can ever achieve that, but we'll try and come close. So next I want to change gears and talk about the largest multi-center international closed-loop control study that was published in New England Journal of Medicine a few months ago. So this was an NIH-sponsored study which over 500 participants in 5 clinical protocols that was initiated, 7 in the United States and 3 in Europe. So basically the objective of this trial was to generate safety and efficacy data satisfying FDA requirements for approval. And the system used the tandem insulin pump and the Dexcom G6 sensor. The algorithm or the electronic brain of the artificial pancreas was embedded inside the pump so that the patient just had 2 devices, the CGM and the pump. So this was the study design. It took a total of about 170 patients with 2:1 randomization to either sensor-augmented pump therapy, that is pump and sensor without the electronic brain, without the algorithm, versus the closed-loop control over a 26-week period, with hemoglobin A1C being the primary outcome variable, apart from other secondary outcomes. So there was 170 patients enrolled, and 2 patients dropped out before enrollment. We randomized a total of 168 patients, and they were randomized 2:1 to either the closed-loop control in pink or the sensor-augmented pump group in blue. And as you can see, throughout the 26-week period, every patient that was enrolled or randomized completed the study. This is a very rare phenomena in a multi-center, multinational study where 100% of the patients that were randomized actually completed the study. This was the baseline characteristics, the mean age, gender, hemoglobin A1C, duration of diabetes, etc., was same in both groups. These are the primary outcomes. Time in range between 70 to 180 milligrams per deciliter at baseline was 59% in the sensor-augmented pump and 61% in the closed loop at baseline. At the end of 6 months, that was increased by about 11%, which was statistically significant in the closed-loop control group versus the sensor-augmented pump. So 70 to 71% was time in range. Furthermore, hemoglobin A1C reduced from a baseline of 7.4% to about 7.0% at 13 weeks and remained the same for about 26 weeks. So as you can see, these were patients with type 1 diabetes that were relatively well controlled. So even in patients with well-controlled diabetes, hemoglobin A1C reduced statistically significantly. And when you break this up into the changes in time in range based on hemoglobin A1C, it was interesting that the most improvement was seen in the patients who had fairly good hemoglobin A1Cs to start with, between 7.1 to 7.5%. So in this group, there was a 21% increase in patients who were fairly well controlled with diabetes. So even in those with well-controlled diabetes, there was significant improvement in time in range. Hypoglycemia was reduced significantly, whether it was below 70 or whether it was below 50. So usually, without the use of closed-loop control, when you try and get the hemoglobin A1Cs down in patients with diabetes, Again, it's true whether it's type 1 or type 2 diabetes. The closer your hemoglobin A1C gets to target, the higher the risk of hypoglycemia. But here in the artificial pancreas situation, even though the hemoglobin A1C is down, the hypoglycemia is reduced significantly. One other important point was that when you look at the time in range, the most important time of the day was early in the morning. So the patient started their glucose values in the morning at a normal range. That means that overnight hyperglycemia was significantly reduced in these patients on closed loop. That was the time. Now, one of the things that we also evaluate in these studies is the patient burden of technology. Taking a pump, having a sensor, and all the rest of it, did it add to the burden on the patient? And the short answer is that no, they loved it. In fact, none of the patients who were in the closed loop study wanted to give up their devices at the end of the trial period. They wanted to continue because they liked it so much. So to summarize this study, 100% of participants completed the RCT and were actively using the system at the end of 6 months. The closed loop system was superior to sensor-augmented pump in all glycemic control parameters tested. Results were consistent across a wide range of hemoglobin A1C from 5.4 to 10.6% and from the ages of 14 to 71. So across the span of age, and patients reported high rates on ease of use, trust, and usefulness of the closed loop system. So this was published at the end of October at NEJM. The FDA approved the device within 2 months of publication. It was commercially available for download on January 20th of this year. And currently in my clinic, we have actually about 110 patients with type 1 diabetes that have upgraded to this system in my clinic. Now, upgrading to this system is very easy, especially if the patients has been on the tandem pump before, because the way that the upgrade is through the web. They do not need to change the hardware. They can download it directly from the web. Of course, they have to pay a price, about $300, but they can download it directly from the web. They do not have to change the devices or the sensors. So that was very convenient. So these are the current commercially available automated insulin delivery systems in the US for personal use. We talked about the Tandem T-Slim X2 with the Control IQ, which is the closed loop system, and we have the Medtronic 630G and the 670G. There has not been a head-to-head trial of these devices, but that's something I don't think most industry sponsors will agree to do. What are the studies that are currently in the pipeline? Artificial pancreas studies in children from ages 2 and above, and we are part of that. Artificial pancreas studies in type 1 diabetes with hypoglycemia unawareness. And we are starting some of these hospital studies along with our friend and collaborator, Dr. Guillermo Ampires from Emory Hospital in Atlanta. We are planning to use artificial pancreas in patients with both type 1 and type 2 diabetes in the hospital, in the step-down units, in the pre- and post-transplant situations, both of solid organ as well as pancreas. Another study that I'm starting, in fact, I've just started, is to use adjuvant therapy, that is insulin plus SGLT2 inhibitor closed-loop study in patients with type 1 diabetes. There are other studies that have recently been published, including dual hormone, that is the insulin glucagon or the insulin pramlintide, or a triple hormone, which is insulin, glucagon, and pramlintide, trying to actually recreate not only the beta cell, but also the alpha cell, the islet as well. Because beta cell makes insulin and amylin, while the alpha cells make glucagon, so it's a triple hormone. Of course, it's a technological challenge which the engineers are trying to overcome. Okay, now we are going to go on a few cases. Any questions so far? Before I just describe maybe 3 or 4 cases that we used closed loop control for better diabetes management. Any questions related to what we have discussed so far? Please feel free. Okay. Any questions? Okay. So we'll go to the first of many cases. So this is a patient with cystic fibrosis-related diabetes. So again, I have about a dozen patients with cystic fibrosis-related diabetes of all ages. And most of the time, yes, they do make some insulin. So it's more like a type 2 diabetes or a pancreatogenous diabetes. But using MDI or insulin with the insulin pump, with or without sensor, improves control. So this is a patient with cystic fibrosis-related diabetes. He was started on the Medtronic 670G system before this patient came to our clinic with no training. The patient was just prescribed the system by his primary care physicians and told, go deal with it. So there was no education, no training given to the patient. And this was the first clinic visit. So basically, the top panel shows from midnight to midnight the continuous glucose monitoring readings, with the black line being the median, and this is the interquartile ranges, and these are the interdecile ranges. And the whole graph is represented as time in range. As you can see, time in range is between, in this case, between 70 to 180 milligrams. About 68% was time in range, and the remaining was hyperglycemia, a time above range. But one important aspect I want to point out is this arrow and this arrow. So the top red arrow shows that the patient is on manual mode more than half the time. That when the patient is not using the closed loop system optimally. More than half the time, the patient is on open loop, while only about 47% they are in the closed loop. And the total daily dose of insulin was about 30 units. Again, not a lot, because these patients also make endogenous insulin. But overall, this was not optimum. If the patient has been prescribed closed loop system, they should use it. So we taught the patient how to use it, how to be on auto mode versus manual mode, etc. And then in the next clinic visit, again, the overall glucose patterns perhaps did not change much, because the time in range changed from 68 to 67%. But when you look at the top arrow, 92% of the time the patient was in closed loop mode. So the patient was using the machine more effectively. And the total daily dose of insulin actually came down from 30 units to 25 units. So the patient was using the automatic mode more efficiently. By the third clinic visit, again, there was not much change. There was some hypoglycemia now, but again, the patient was using the automatic mode more efficiently, and the insulin requirement came down even further, down to by almost 50%. Without any major changes in the overall glucose control, just by using the automatic mode more effectively, the patients were using about 50% less insulin for the same glucose control. So again, this shows that the automated devices are really pretty good in keeping the glucose control reasonable and also reducing the amount of insulin required to control blood glucose. So this is really, because yes, insulin is not harmful unless given in very high dosages. But if you can lower the insulin requirement by 50%, that will also lower the expense that the patient have to pay for buying insulin. Now, here we have another patient, obese patient with type 1 diabetes. I think this patient actually had a BMI of 35. And this was also, the patient was on the Medtronic 670G system. So again, the first clinic visit, 83% time in range, but significant hypoglycemia, about 13% time of hypoglycemia. This patient was better versed with the use of the system, and hence was using the automatic mode almost 90% of the time. But the total daily dose of insulin was close to 100 units. And the bolus dose was 80%, more than 80%, while the basal was only 20%. Despite the fact that this patient had type 1 diabetes, the amount of bolus dose that the patient was using was far more than what is usually recommended, which is 50-50. So again, we provided education and how to use the artificial pancreas device more effectively, talk to the patient about carbohydrate counting and so on and so forth. Next visit, the glucose control, almost everything was within goals. Again, about 88%. There was still some hypoglycemia, but it reduced from 13% to 6%. But most importantly, the amount of insulin required came down by 25%. So at 99 units before, and now it's 75 units with, I would argue, better glucose control than before. And the patient was using the closed-loop system 97% of the time, which is pretty good. Third clinic visit, again, there was perhaps further reduction in hypoglycemia. Time in auto mode, 96%. Of course, now the total daily dose went up to 95%, but then the proportions changed. The patient is using about 70-30, 70 as bolus and 30 as basal. Okay. All right. This was especially a challenging patient that we saw in our clinic. Type 1 diabetes for 24 years, initially presented in ketoacidosis, poor control, was initially on a pump, then changed to an MDI, and did not have great follow-up. This patient was understandably depressed, and the patient wanted to get pregnant. Her hemoglobin A1C was 14%, not ideal for pregnancy and conception. Patient was previously on insulin pump therapy, and as I said, DK episode in the past 1 year. Patient started using a CGM. Patient also has hypoglycemia unawareness. So a typical patient that I see in my clinic almost every day. So the first clinic visit, this was the first use of Medtronic 670G in the patient. Again, not optimum. 63% time in range and about 37% hyperglycemia. Patient was in manual mode 100% of the time, not using the closed-loop system that she was prescribed, and the total daily dose was 61 units with about a 50-50 spread. Second clinic visit, significant improvement. Time in range went up to 80%, automatic mode in 97% of the time, and the insulin requirement came down to 46 units. So improvement in every way. Third clinic visit, further improvement. Time in range now 87%. Total daily dose 54 units, and we could compare it with one of our previous times that, from a few months ago as to what her glucose control was on the same device. With these devices, these closed-loop systems actually learns from experience. They have something called machine learning and artificial intelligence that is built into the system. So these algorithms learn. So even with simple use, daily use of these algorithms learn from the patient's experience. So again, overall improvement in glucose control. Again, this is just an example of various patients that we've seen. This is a patient with type 1 diabetes who is a marathon runner, runs half marathons almost every weekend, and marathons 3 to 4 times a year on type 1 diabetes, initially on multiple daily insulin injections. Patient was changed to the basal IQ system. Again, I've just shown a few examples. Highest glucose reading was 202, average glucose 114, lowest 65. So despite running the marathon and half marathons, he's avoiding hypoglycemia. Time in target was 96%, which is amazing for any patient with type 1 diabetes, leave alone someone who's a marathon runner. Again, so this patient we see very frequently, especially during the summertime when he trains more intensively for marathons. So we sometimes see them every few weeks and make adjustments to their algorithms, but pretty good. 97% time in range. Of course, these patients themselves are highly motivated to keep their blood sugars under control. So I think at this time, I have only 5 minutes left. I still have some more patients, but I wanted to generate more discussion. So I think I'll stop here and take any questions from the audience and from the chairpersons.
Thank you, Dr. Basu, for an excellent presentation in a somewhat a difficult topic.
It is very difficult.
So we invite questions from the audience.
Please.
Automated insulin delivery, how does it deal with the bolus?
Yes, that's a very insightful question. So although it is automated insulin delivery, it is not completely automatic. So the complete, a full closed loop control system is not yet available. We are working on it. It's not yet approved. It's not yet available. So with the bolus, all that the patient has to input is the carb amount, the carb content. So that the patient still has to input into the system every time he or she eats a main meal. For smaller snacks, they don't need to.
Yeah, that's exactly my point. So most type 1 diabetes patients, at least when I meet them in India, most of them don't know how to do carb counting. So that is the biggest problem. So even with CGM, it's really a big challenge here to get them to do the carb counting.
Yes, and that is still being the, what shall I say, the holy grail of the automated insulin delivery systems. One of the thoughts that we have had, and that is one of the clinical trials that I've just started that was funded by the NIH, is to limit postprandial hyperglycemia. And how can we do that? We can do that with adjuvants like SGLT2 inhibitors that can reduce postprandial hyperglycemia in patients, even in patients with type 1 diabetes. So in this clinical trial that we have started, in fact, the first patient was enrolled about 2 weeks ago. We are not doing carb counting. So we are in the test arm. Of course, this is a randomized control trial on SGLT2 inhibitors with closed loop versus closed loop alone. So in the SGLT2 arm, in both arms, we are not doing carb counting. It's a short-term study just for about 6 weeks. We should have the results later on this year. We'll see how that goes. But without that, without use of adjuvant therapy, whether it's SGLT2 inhibitors, whether it's pramlintide, or whether it is GLP-1 agonist, current approved systems still need to inform the algorithm with the bolus, for the bolus dose with carbohydrate counting. So maybe 2 years from now, if these trials show that using these additional therapies allow us to use completely automated devices, that should be better, but we don't know yet. And that is partly because, as you know, the Lord above has made us perfect. When we eat, after we ate our lunch, after the carbohydrates are absorbed, it goes straight into the portal vein. The portal vein feeds the pancreas. The pancreas sees the rise in insulin. The insulin goes straight into the portal vein, into the liver, where half of the glucose is stored as glycogen and the rest comes out. Here, what we are doing is giving insulin into the systemic circulation. So there is a delay, not only in insulin action, but also in glucose sensing. So again, this is a subcutaneous closed-loop system, which, try as hard as we might, we cannot mimic and cannot reproduce what the Lord above has made us. So again, we cannot hope to achieve complete euglycemia with any of these artificial pancreas systems that are currently being tested and available. We are doing some early studies with intraperitoneal closed loop, with implantable sensor. Again, those are very early studies that we're currently doing. That may be closer to normal physiology than the sub-Q closed loop. There was another gentleman.
Hello? Hello? Okay. No, this is a different kind of a question. In our body, where exactly is the primary glucose sensor? So typically we talk of glucokinase and the beta cells in the islets of Langerhans, but gastroenterologists will have us believe it's in the duodenum because the enteric endocrine system is the largest endocrine organ in the human body. And the gut with its appendages, liver and pancreas is very important for diabetes. So from that perspective, to look at just the pancreas, what I was looking at, is it like an artificial enteric endocrine thing rather than only the pancreas? Because it's not just the beta cell which...
Absolutely. And again, that's a million-dollar question. So, you know, we think that the beta cells with the glucokinase is the primary glucose sensor. But as you know also, there's human data that suggests that glucagon is made in the gut. Not only in the pancreas, in the alpha cells, glucagon is also made in the gut. So again, we have a lot to learn. We do not yet know what is the primary thing. And the brain also plays a role. There's no question about it. The hypothalamus also plays a role, not only in glucose control, but also during hypoglycemia recovery. So again, there are multiple factors. The topic that I am most, from the scientific standpoint, I'm most interested in because, you know, insulin has been studied and studied for almost more than 100 years, since insulin was discovered by Banting and Best in 1921. But the alpha cell has been ignored for a long, long time. We do not know yet how much glucagon is secreted in a day, where is it metabolized, what metabolizes it, what regulates it. So I actually have an NIH grant looking at alpha cell physiology in normal humans and in patients with type 1 diabetes. How are alpha cells, how is glucagon secreted, how much is secreted, what controls glucagon? Is it just insulin? Is it glucose? Are there other factors? We talk about the paracrine regulation within the pancreas, alpha cells, beta cells, and delta cells. But is it truly paracrine? Is it all within the pancreas, or is it somewhere else? Lots of questions. So not our generation of physician scientists, but the next and the next generations will answer most of these questions. But we don't know a lot of these questions. We take a very simplistic view.
So what is the cost of closed loop system there in the United States?
Very good. So the cost of closed loop systems, since these systems, at least the Medtronic 670G, the 630G, as well as now the Tandem Control IQ, is approved by the FDA. Most insurers have started to pay for it. But again, you know, if you pay out of pocket, the initial cost of starting this system is close to about $5,000 to $6,000, which comes to about 3.5, 4 lakhs, I think, right? Mm-hmm. But then there is a monthly, cost of close to $1,000. So yes, most patients paying out of pocket obviously can't afford it, but now because this has been approved by the FDA, more and more insurers are covering it, at least 80 to 90% coverage.
So thank you very much, sir.
Thank you.
For your brilliant presentation. Thank you. So we conclude the session.
Yeah. Hello. Thank you, Dr. Ananda Basu, Dr. Mohan Shenoy, Dr. Kundan Khamkar, Dr. Raghu Satyanarayan. I would now like to call upon stage Dr. Sadanand Raut to chair the session.